Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Jane Bailey, a neuro-ophthalmologist and comprehensive ophthalmologist with more than 20 years of cataract experience, who made the bold decision to go back to fellowship mid-career. Tune in to hear Dr. Bailey's journey of reinvention, service, and leadership in ophthalmology.
Today we are joined by Dr. Jane Bailey, a neuro-ophthalmologist, comprehensive ophthalmologist, cataract surgeon with over 20 years of experience, and a deeply respected physician leader. Dr. Bailey serves as medical director of Park Nicollet Same-Day Surgery and of the Burnsville campus. She has practiced across academics, private practice, and for 13 years as a United States Air Force officer, where she embraced the core values of integrity first, service before self, and excellence in all we do. After more than 2 decades as a cataract surgeon, she made the bold decision to return to fellowship training in neuro-ophthalmology at the University of Iowa mid-career, redefining what professional growth can look like. Dr. Bailey is known for not only surgical excellence, but also diagnostic expertise and for being a physician who listens. Her achievements span academic research, national leadership, including service with the American Board of Ophthalmology, military honors, community service awards, and mentorship. Dr. Bailey, welcome.
Thank you.
We're so excited to have you on the podcast because of your unique career journey. Can you start by just, for our listeners and for us, just framing your walk into ophthalmology and throughout your career?
Sure. I trained at the University of Iowa, which is a wonderful experience, and as you know from having trained there yourself. And I was an Air Force scholarship recipient. So after doing an extra 6 months of peds and plastics at Iowa, I started my Air Force commitment as a comprehensive ophthalmologist, doing a lot of cataract surgery, but also a lot of everything, honestly, which was really exciting. And those early career years are years of great growth and learning, especially learning how to be a leader in the clinic, how to teach the techs, how to make everybody patient focused and help other people grow as you're growing. And then after private practice, group practice, a number of settings, including 7 years of solo practice, which is actually a pretty common practice setting for ophthalmologists, surprisingly, has its own set of gifts and challenges. I was, in a word, burned out, and I had started to focus so much on cataract surgery and dry eyes and speeding up the clinic, seeing more and more patients with a more narrow band, glaucoma, and so on, that the thrill was gone. And I sat down to decide what was missing and how I could love my career again. I loved the patients, I loved my coworkers, but I didn't want to go to work. And what I discovered after some introspection was what I loved about medicine as a medical student was the delight of learning new things, the delight of working across specialties and learning from others, and the mysteries of the diagnostic dilemma, and how satisfying in this time when we have incredible diagnostic tools to be able to help solve problems that patients have been going here, there, and everywhere to try to solve. And unfortunately, the answer to that problem is neuro-ophthalmology, which is something most comprehensive ophthalmologists moan and groan when they have to see. And that's what led me to think about a mid-career fellowship.
So was your practice already building in like patients who needed neuro-ophthalmology? Were you starting to have like that interest already? Like, tell us about the pivot.
Yeah, it doesn't make sense. It's shocking. And people, when they hear that I've done this, comprehensive and cataract people that I've known, they're either kind of intrigued or they're just disgusted and think I'm insane. And the reason for that is that if you have a patient care day of 45 patients with cataracts and glaucoma and all the other things, one double vision just ruins your day.
Yes, that's why
Sorry, Dr. Botham.
I'm interested.
Right, exactly.
How did this happen?
Or one unexplained vision loss. And so those things, when you're in private practice, because you don't have easy access to imaging and labs and all the hour-long conversation, those patients get referred. And so that was not an option, but I always was curious about what happened to those patients and how did we figure out the answer to their problem. But when going back to my training at Iowa, the neuro-ophthalmology rotation, as you know, is a much different pace. And I trained with Stan Thompson, who is a genius. But the most remarkable thing about him as a physician, not only his incredible compassion, but his curiosity. And again, he was tickled pink when he got an answer to someone's problem. Mm-hmm. And that struck me as how I wanted to be 20 years and 30 years later after my training.
For the listeners who are hearing that word burnout, which you used, what does that feel like? What is that emotion? And I'm sure people are potentially considering changes in their own career, and they may have a hard time like leaning into that and listening to that and maybe changing. And this is hard to do. So what is burnout?
Well, the best encapsulation I got from, I think his name is Daniel Pink, who wrote Drive, that what motivates you in your work life are three things. One is autonomy, having some feeling like you have some control or agency. The second is the opportunity for mastery, and that is something that for most people who go into medicine is very motivating. Mm-hmm. And the third is meaning. And you would have a hard time finding a profession with more opportunity for meaning. Unfortunately, sometimes your job, and sometimes this is self-inflicted because we feel like we have to be efficient, and so we have to do X number of injections a day, or we have to sign up X number of cataracts a day. And what you've just done is you've taken away your sense of agency or control. Mm-hmm. You've taken away that mastery. You've coned it down so much that you're not maybe learning as much, at least with breadth, as you could in medicine or in ophthalmology. And third, if you can't converse with the patients and understand what they're going through before your treatment and your relationship and after your treatment and your relationship, a lot of the meaning it's still there for the patient, but it's not really there for you. Mm-hmm. And so what's left? It's just a paycheck at some point. You're very expert and you're doing a good thing, but it doesn't mean you feel good about it.
So certainly I'm certain that sense of a wick being shorter or not having quite the flame in the practice. People have different seasons of their life. Mm-hmm. But for so many people, you commented on control. And for a lot of people, they don't feel like they have control of their practices or of their choices. But tell us a little bit about, you found control by radically changing your practice. And I think that was, in addition to your leadership things that we're going to get to here too, I'd just like to know a little bit about your fears, your barriers to say, I'm going to take control and I'm going to go back to fellowship. And just that sense of financial, professional, personal insecurity, uncertainty, because sometimes we stay in our groove because it's the only groove we know. But to go back after 20 years and be a fellow that is a really big sense of I'm taking control of my career in a new way. So
before you answer, was it 20 years that you had been in practice, or when was the fellowship?
Yeah, so I left my residency 96 and started my fellowship in 2017.
Okay. All right.
So as
I'm
you got
interested
close
in the answer.
28 years in, when you look back, what were your biggest fears or barriers that made you wonder, should I really do this? And would a lot of times leave people paralyzed.
Yeah, there were so many reasons not to do this. I was a partner in a very good, great practice, the money, the stability, all those things. There were some things that well, first of all, I was pushed to do it because I was so burned out that I was going to leave medicine or leave ophthalmology. And that seemed like a shame. I had put so much into it, and I knew a few things. And so there was that. I would say it was an approach avoidance conflict. And the second thing that happened was my oldest kids were looking at colleges. They were about to graduate from high school. So that felt like this big milestone. My oldest kids are twins, so it's double the departure. And sitting at the dining room table with them and them talking about, I want to take these classes and I want to do this. And I just had this horrible negative feeling, not because they were leaving and doing great things, but it turned out to be envy. And so it was the timing of it. And then my husband is very supportive, and he recognized the burnout. And I'm usually a very bubbly, energetic, positive person. And, I'd be in the car with my forehead on the steering wheel trying to get out of the car at work. And so his reaction was, okay, what do we need to do to make this happen? And so I think a lot of things had to fall into place. I do think you're exactly right that people feel like they don't have control because of their family situation. I have to live in this town and there's only these jobs, or because I have to earn this amount of money during these years, or I need this certain support if you're in academics, so I need to just take whatever abuse whoever I work for wants to give me. But I think if you really zoom out, you can figure out what your top priorities are and figure out ways to change them. And I think even taking control of your day and putting some of that meaning back in it. And for me, it wasn't, spending a lot of time talking about my glaucoma patient's grandchild. It's nice, but that wasn't the meaning. And I really needed that challenge of the diagnostic and working on a team, multidisciplinary team. I think those were things that I thought in theory would give me satisfaction. And then when I was taking time with a patient, it wouldn't make me impatient. It would make me more satisfied and feel more helpful and effective. And that turned out to be true. And I was just lucky that I picked a specialty and that I'm now in a health system where teamwork is the absolute, is a really high value.
So going back to training, what was training like as a fellow compared to when you were back as a resident decades prior? And what was maybe something that was surprising to you when you did go back and enter the training phase?
Yes, well, as you had the opportunity.
And by the way, you were my fellow
to
for all this
witness,
history.
yes.
I was a resident in Iowa, and she was
the-
my fellow. Very intimidating.
Right. And Brittany was the best resident ever. I can't believe what you do and how hard you work to make the patient's experience so exceptional. What makes being a fellow, and I'm sure you recognize this from being a fellow, that is more difficult than being a resident is that when you're a resident, everyone knows you're a PGY whatever, and they know you don't know much. When you're a fellow, on the very first day of your fellowship, they all look at you and say, oh, this person's going blind, what should we do? And what I recognized immediately, which shouldn't have been surprising to me, but it was, is that in my comprehensive practice that I've been doing for 20 years, I could do it blindfolded with both hands tied behind my back because I had all these heuristics. The lowest part of my brainstem was making all the decisions when I walked in the room. I knew exactly what they had and what to do and what to tell them. And in some ways that feels good. But when I walked into neuro-ophthalmology, even though I had studied and I knew a few things, I felt like I had walked off the plane and everyone was speaking Urdu. And it took a long time to get those things. I still learn new things every day, But now I have the heuristics where I can immediately categorize, I can sort and categorize without doing all that really strenuous thinking. And so I think for fellowship, that was the hardest thing. It's incredibly humbling when you're 50 to just be lost and to say, I'm lost. Help me look at this MRI. I mean, if it had been a piece of film, I could have held it upside down and thought, I don't know, this looks pretty good. So I think there's that. But there's advantages to training when you're a little more mature. You may not have the incredible stamina and working memory, like being up all night in the emergency room where all of you went to the phaco course and I had to stay and take calls. I was tired, I'll be honest. But you're sort of, I don't know what to call it exactly, but maybe like your moral decision making. There are scenarios where my colleagues who were, 28, aren't sure what to say to a person or what to do, whereas I just had enough life experience to say, okay, give that person a Kleenex box, and then this person we're going to take down the hall and have this conversation. You know what I mean? Mm-hmm. So there were those situations that weren't as stressful for me. Mm-hmm. But I learned so much, not as quickly as I would have liked, but I did learn a lot.
It's a wonderful perspective. I've trained fellows for most of my career in pediatric ophthalmology, and one of my special memories was training Jeff Tufte, who's out in Sioux Falls, and he was a retina specialist for 10, 15 years before he decided to go back and do peds. And I was so blessed as the mentor to do to just have someone that was similar age, and just to be able to approach the patient care with some wisdom and empathy as a physician, but yet with a new hunger, as you're describing in that regard. So understanding the fruit, and then we're going to get to your career since. But what advice would you have for individuals, even if they're not in burnout, but they're considering options of changing their practice, whether reinventing or reshaping what they're doing? What advice do you have for the listeners out there on how to approach that, how to step into it? Any thoughts in looking back at what you did to guide them or give them encouragement?
Yeah, I am not great at all these things, but I do feel like I have some insights. And one is that I think what I see a lot of my colleagues do when they have been at it for a while and it's not brand new, and if they're feeling a little exhausted or frustrated by kind of bumping up against the same problems, one of the techs left and we have a new one now and that's annoying, or those kinds of things, is they take more vacations and they go to more wonderful places. And I'm not saying that there's anything wrong with that, but the more you have all of your joy somewhere else and you just tolerate things at work, you can imagine, as with a relationship, your relationship is going to suffer from that. So I think you have to be somewhat purposeful and say, here are the things that are enjoyable or meaningful to me, make me feel like I have some control. I think the power of habit is amazing. And one of the things that I really enjoyed as getting towards the end of my, many, many years of cataract surgery, is I would watch a video every morning, because now there's so many videos, and like Uday Devgan has these great cataractcoach.com videos, and I would just watch one every single morning that was my OR day morning, and it would just get me so fired up because I'd be like, oh, that's really cool. And there's just little tweaks and little things. So find ways to have a lunch break, to stretch and walk, and find ways to enjoy the actual job, and don't just sort of soothe yourself with your activities outside the job. Not that those things aren't important.
Yeah, that makes sense. I feel like that's important for all of us to remember to get excited about what we do. And watching videos is an easy solution. that I think a lot of us could do that. Okay, so how do you combine the two worlds of comprehensive ophthalmology and neuro-ophthalmology? And I'm asking about like logistics. How do you actually do this? What is your schedule? What is a normal week for you? Walk us through how you make space for very different specialties in ophthalmology.
Yeah, that's a great question. And when we go to NANOS, the Neuro-Ophthalmology meeting, everyone talks about this. What are you doing? They want to know exactly what the schedules look like. I separate it, and there's a pretty firm wall. So I do Neuro-Ophthalmology clinic Monday and Friday, and I have a partner, Ahana Bibi, who's amazing.
Love her. She was also my fellow.
Your resident. And she has clinic Tuesdays and Thursdays, and then I also triage on Wednesdays. And then I do comprehensive on Tuesdays and every other Wednesday. And for me, I like it. And I will say it's a myth that neuro-ophthalmology is a non-surgical specialty, in the sense that most neuro-ophthalmologists do surgery, whether they're also cataract surgeons because they do comprehensive. That's pretty common.
Yeah.
And
what's the percentage of specialists who do cataract surgery? Is it most, or
in neuro-ophthalmology? Well, first you have to separate the neurologist from the ophthalmologist.
Sure. Okay.
So half of them are ophthalmologists, and of the half who are ophthalmologists, I would say maybe 25 to 30%. That's just a rough guess. And then there's quite a few who do orbit and oculoplastics, and then there's quite a number who do strabismus. So, and if you think about it, they all make sense. We even have a few who are glaucoma and neuro-op trained, like Reed.
Yeah.
And so that's actually pretty common. And it is, I have to say, I don't know of anybody who can do neuro-ophthalmology 5 days a week, just because it's so intense. And there's so much follow-up, and there's so many labs and MRIs and communicating with other specialists. And I don't think I could. And so it is actually kind of nice. Like this morning I had my glaucoma follow-ups and my iritis follow-ups, and I had a lid dermatitis, and I had some lid surgery follow-ups, and you just bop along.
Change your pace.
Yeah, and it's a different kind of part of your brain. Especially the surgical stuff is a different kind of part of your brain where you can kind of let your perfectionism go nuts, because that's what you're supposed to do in there. And whereas in neuro-ophthalmology clinic, it's going to be messy, and there's going to be a lot of times where you don't get an answer, which is not so much the case for a lot of the other things we do in ophthalmology, where you just see it and you know what it is. You know it's a corneal ulcer, or you know it's a CNVM, and then
treat it.
It's right. It's more of a therapeutic dilemma than a diagnostic dilemma. And so I like the balance in the mix. So that's how I mix it up. I do know some neuro-ophthalmologists who do comprehensive. I have a good friend at Michigan who just mixes them together in her clinic. I don't know how she does it, but so she just short visit along. But I'm always afraid I'm going to be trapped in the room telling someone they have multiple sclerosis for an hour,
and they get backed up with 6 patients
and then
ready
I
for
just
you.
have a quick IOP check, who's been waiting for an hour, but to each his own.
Yeah, I was going to ask you specifically about the advantages, but you articulated that so well, of just the changing pace from to have a surgical practice niche that way. Can we talk about advocacy? So you've played a number of roles in between private practice, even a solo practice you shared with us, group practice settings. You've been in academic arenas. Share with us just a little bit about how now, because I appreciate your voice and your role at the Minnesota Academy, but I appreciate also your role across the American Board of Ophthalmology. You've had a lot of leadership hats. You even talked about burnout early, but you're wearing so many hats. What drew you into the advocacy and organizational realm of our practice?
Well, I can tell you, when I was in practice in Nebraska, I remember going to a meeting, and actually the medical society was, they were calling for volunteers to kind of do song parodies. And I thought, well, that sounds like fun. And then I got this lecture that, well, you can't just do the fun parts. You have to do the advocacy parts. But what they impressed on me there, the leaders there, was that there's nothing more sacred and special and important than that communication that you're having with the patient one-on-one in our little dark 5-foot room that we spend our time in. But that ultimately, for the health of that person, you as a physician can have an outsized influence on their health by working with the state legislature to we got cigarette smoking out of restaurants in Nebraska when I first moved there. We put limits on tanning for minors, along with the dermatologists and all these other things where your voice carries a huge amount of weight. And I think a lot of physicians aren't aware of what their voice can mean. And selfishly, the relationships that I've built among other ophthalmologists and among other medical specialties have just been a real enrichment and part of anti-burnout. So even though it does take some time, I think it's been, I've gotten more than I've given in that realm for sure. And right now I'm in the leadership development program.
That's awesome.
It's just so much fun. And don't tell anybody, but we're doing a secret flash mob for our leader in Washington, D.C. in April.
Do we need to edit that out?
No, because we will do this.
Don't tell anybody, but I'll tell the world.
Before this one person finds out, we will have done the flash mob.
Okay, there you go.
Okay,
yeah.
sounds
It's at
good.
we're going when we go to the Capitol for mid-year forum.
Okay, fun.
Yeah.
Now everyone knows.
Now everyone knows. Yeah.
So for people who are listening, what is actionable that they can do? What does it mean to be an advocate as an ophthalmologist?
I think that's a great question. I think that our state society is a great place to start because we are a community of ophthalmologists, and we are not in competition with one another so much as we are all trying to row the boat in the same direction. And it's great to learn from one another, and not just from each other, our specialties and our professions, but our office managers and our technicians have so much to learn from one another. And I think the more bonds that we can have there, the more we can do. That's actually my leadership development program project has to do with a statewide grant that the joint, training, it's for apprenticeship programs for technicians, completely free for practices who have hired a technician within the last 3 to 6 months who is not certified, and they'll provide all of the education, all the educational materials, the exam. They'll essentially, you can go from having a front desk person become a COA in a year, which is like a $20,000 value, because our training programs both closed, unfortunately, in the state recently. Mm-hmm. And you can get them completely trained and COA certified for free through this workforce development grant through the state. So things like that benefits all the practices. I do think that there are a lot of issues that come up where we can work with other medical specialties. One is gun safety. That's a big issue at the Capitol right now because of of course, mass shooting that we had in Annunciation, and other issues like that where physicians' voices are so important. I think the Academy has lots of good opportunities. The American Board of Ophthalmology, all the specialty society have great opportunities.
You commented on appreciating your current role at Park Nicollet, valuing and really being anchored in teamwork. It's something that Mayo has had great cultural pride in and fosters. And then you're commenting now about the importance that you see in terms of investing in your techs and in people on your team. Given your variety of leadership roles, and then understanding that so many people day to day, we talked originally about burnout and difficulties, a lot of it in many people's offices are in relation to the challenges with other people, getting the work done in the same way you want to have it done. And that might be relationships up the administrative or leaders above you, and it's also in relationships to people that are on your team around you. So share with us, just as a leader, as someone who's worked in private practice where you had to maybe shoulder a lot yourself and now you're in a group setting, what lessons do you have or what advice do you have for how to invest in, how to cultivate, how to prioritize the relationship with people around you as you care for patients?
I just think that is such an important issue and something I think we don't talk about enough. And I will say that when I left my training, I had this idea of what my job was, that I was the doctor and I would take care of the patient, and other people in the clinic and in the OR, they would do their jobs, hopefully perfectly, and then it would just all work, right? Like it was an assembly line, and there was this other, and then I got into my first job, which was in the Air Force, and it's a closed system, and the people who are your technicians in the office and in the operating room are enlisted people, and enlisted people in the Air Force are not like employees. They are your younger siblings that you are not firing if they don't meet standards. You are responsible for getting them to meet standards one way or another. And it was a big, I learned this from my non-commissioned officer in charge, who was mentoring and fostering the development, and by turns browbeating and encouraging all of the people around until they were growing. And I think seeing that as part of your job, I feel like we have so much on our plates, but it absolutely is your job to help those people along. And one of the things that I found is the most effective is that if the other people in your office want those same things out of their job, they want meaning and autonomy and the opportunity for mastery. And if you're just going into the room and closing the door and coming out and telling them to do this, that, or the other test, and you're not sharing with them the meaning and, the before and after pictures, or the look, this he was 2070 and now he's 2025, and if you're not sharing with them the beauty of the journey and the meaning, and also let them make decisions that make sense. And so you have to think about those three things for your staff, and they will love you and never leave you. And it doesn't mean you can't give them feedback. We're also not great at giving feedback, but I think that's all very important.
Well said.
Yeah, we're talking a lot right now about technicians, specifically new technicians, and I have a new technician. She was a tech in dialysis for 20 years and now is in ophthalmology, which is a completely different language, right? And so it takes patience, and it really does take leaning in and educating them. And one thing that I've realized very recently is they have to come in and be in with you, listening to the patients, hearing the discussions, seeing the OCTs, understanding what we're actually doing and the impact. And it's been a game changer. And I feel like we're now like partners. She's not just a tech that I work with. Like, we are providing good care together. Yes. And she's starting to like get handouts together and saying, I can do this spiel for you, like the dry eye spiel, because I know you have to go see patients. And she's good at it because she's heard me do it now. It's all about empowerment. And she's getting excited, right?
Yes.
And I'm starting to get excited just thinking about it, because it's really nice to see someone grow in that way.
Yes.
So thanks for bringing that up.
And I love that you're modeling for her what you want the patients to hear and learn. And it's a big win-win for everybody.
For sure. Can we talk a little bit about professionalism and competence? Correct me if I'm wrong. You are the chair and founder of this committee for the board, or
right? I think it has a better name now, but yeah, yes,
that's what it started as. So
engagement, okay. I'm not sure what the name is now. I've been off the board for a couple of years, but yeah, when I started on the board might have been like 2014 or something like that.
The American Board of Ophthalmology.
The American Board of Ophthalmology.
Correct.
Yes, when I became a board director, after many years of volunteering for exams and exam development and things like that, what I learned about certification was that the column labeled professionalism, the only part or curriculum or requirement was to have an active state license, medical license to practice, which is an exceedingly low bar that's, connected to professionalism, but it's sort of, your professionalism really has to go out the window before you lose your state license to practice. And so I think over those years, we built up we had sort of in some ways put the cart before the horse, because having adequate knowledge to practice, yes, important. And for sure, when the board was founded in 1916 or something like that, people with inadequate knowledge were a real hazard, because that was before, Flexner, and medical education wasn't very good then, and people could just put out a shingle and then do all kinds of damage. But now I would argue that a big part of the danger and the fears that the public has, rightfully so, is really related mostly to professionalism, poor communication, greed, that leads to care that's substandard and things like that. And so I think that professionalism has risen. It's not necessarily something you can test with a 4-part multiple choice question, but I think making it a much more important part of the conversation in board certification and certainly at academy functions, I think is really important.
What lessons have you learned? Because certain those topics of professionalism and competence can be uncomfortable at times in medicine, but there's, as you're articulating, it's critical for our overall mission. But in terms of what the board you've helped be part of in terms of the board's making that a priority, what message or what communication would you share with the ophthalmologists out there that don't understand how that's being valued and how it's being equipped in their practices or for our society?
Yeah, I'm not sure what aspects. I think one of the many parts of professionalism is lifelong learning, and so I think there's an emphasis on that. When COVID hit, I worked a lot on getting people their improvement in practice certification by just having them submit what they were doing to protect their patients from COVID. And the thinking behind that was that we had gone back and forth about improvement in medical practice. There was a time, you probably recall, where you would do these projects, and let's say if you had kids with amblyopia, you would take 10 charts and say they had this vision and we patched them and now they have this vision or something like that. And it's just very hard, especially now when we have electronic medical records, to require people to do an improvement project entirely on their own and submit data. And it's just, I don't think that's a really great thing. So the idea is, if you can recognize things that people are doing for improvement and professionalism, we're bandwagon folks, and you can encourage everyone else to jump on the bandwagon. So we have awards around that. And it was amazing to me to see hundreds and hundreds of ophthalmologists, a lot of whom weren't very busy when there was a COVID shutdown, but they had to research and figure out what to do with their practices to balance the dangers of the pandemic with the importance of making sure that their patients weren't going to be harmed, their macular degeneration and glaucoma and strabismus and amblyopia and all these patients. And it was beautiful how much they cared and what they were doing, and how other people looked to that and said, oh, I think we can do better. We can check pressures in the parking lot and all the cool things.
Yeah, so speaking to growth of our specialty, we constantly are trying to get better. What are you the most excited about when it comes to neuro-ophthalmology and comprehensive ophthalmology? Looking, say, 10 years from now, what excites you? Going back to that word excitement and joy.
I think in neuro-ophthalmology, just imaging and testing gets so much better, and there are so many new treatments for things that used to be a real dire diagnosis. And when I think about, we see a lot of brain tumors and metastatic tumors We see a lot of multiple sclerosis and other autoimmune diseases. And every week I'm looking up new medications, of course, that have their own neuro-ophthalmic side effects sometimes. But that's exciting to be a part of, because there are some people that you think wouldn't have survived, and suddenly you see their tumor disappear. And there's some amazing things going on there. I will also say neuro-ophthalmologists are famous for spending way too long on a note that no one reads. And now we're getting ambient dictation that will sort the conversation into a note that's somewhat controlled, or at least doesn't take a lot of dictation or typing on the part of the neuro-ophthalmologist. Those are definitely exciting things. I think the world of probably the most exciting thing in ophthalmology is something that you're working on, which is translating treatments for genetic and inherited eye diseases, which I just think the sooner the better.
Working on it.
Yes.
Yeah, no, it's really exciting for sure. And that's what wakes me up in the morning, and that's what I'm thinking about when I'm on my way to work. So, yeah.
We
That's
love sharing our joys and hopefully wisdom with our trainees, and just thinking about your career journey, your life, certainly your passion for continuing to be a lifelong learner, but also just appreciating how to maintain and foster your joy in the rigor of it all. If you were sitting, for the trainees and young ophthalmologists out there, what takeaways would you ask them to ponder in terms of looking back at your career, which isn't done, but in terms of the steps you've taken? What things would you share right now for listeners that are just starting in an ophthalmology role?
Starting in an ophthalmology role, I would say stay curious. I think that's incredibly important. I think you don't serve your patients well when you have run out of curiosity in that individual person. And it just makes it so much more fun if you're curious. I think that you should keep an open mind about your career and stay in tune with what does bring you joy and mastery. And I do think that you need to know what your comfort zone is. And we tend to, particularly in the operating room, have a very locked in comfort zone. But I think in life, you have to push yourself out of your comfort zone pretty regularly in order to grow and keep growing.
Well said.
Yeah. Well, Dr. Bailey, it's been a joy to have you here. I mean, it's really shown us that the journey of a medical career is not usually linear, right? And it often has surprises, and sometimes we even surprise ourselves. But when we lean into curiosity and excitement and really remember why we're doing this, it makes it really worth it. So I appreciate you being on here and teaching us and our listeners. Thank you.
Thank you. It's been a pleasure.
Mutual. Thank you for sharing your story with our listeners.
Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.